Okay. So we're talking about meniscal transplants. Why don't you take this case?
Okay, so this is a 44-year-old male with knee pain. We have the coronal and sagittal. Looks like there's some increased signal within the posterior body of the medial meniscus, and then it looks like the anterior horn is gone.
So in this case, the anterior horn is gone.
Yeah.
And patient trauma, we can see a
blunted posterior
horn back here. Let's look at some more images. Let's see. Here's so you can see that there's actually displacement of the meniscus and the arch. So the anterior horn and body are really medially, laterally and posteriorly displaced, and we can see there's some articular cartilage disease here. So this is a huge meniscal tear. You'd like to repair it, but if you get in and you can't repair it, if you do a partial meniscectomy, then it's pretty much the same as a total meniscectomy. This patient is relatively young, but especially if they're in their 20s and 30s, young athletes with intact cartilage, then the prognosis to do a meniscectomy in these patients is not great. And so you, like other options, a meniscal transplant is now a favorite option for that group. And it's been a number of studies now shown that they're more likely to go back to the same level of sports play if they have a transplant rather than a partial meniscectomy if you have a large one like this. And the long-term prognosis is pretty good now for those individuals. This individual is a little bit older, had some articular cartilage disease, so isn't an ideal candidate. But then, as you can see here, about 3 weeks later, the patient ended up having a meniscal transplant, and here's what the study looked like the day after the transplant.
Looks like, especially on that sagittal view, you can see a lot more meniscus in that anterior horn when you couldn't see any before. So.
And here you can see the drill hole for the posterior suture. Mm-hmm. And here actually all three. There's one that goes to the anterior horn, one that goes to the posterior medial part of the meniscus, and one that goes to the posterior meniscus attachment.
One thing that I may mention, unilateral problems of knees these days in 44-year-olds are treated with partial knee replacements, and they have become very, very good in terms of length of function. And so I think if I was 44, I'd go for a partial knee replacement. We used to do that, Marmer and I, in the 70s. Dr. Marmer got into a battle with the company, and well, I stopped working with him, but the results of his prosthesis, and he had thousands of, I don't know, a few hundred of orthopods come visit St. John's Hospital here in Santa Monica, and they started doing them, and eventually stopped doing them because they were not working very well. The problem was that the most common prosthesis that was put in had the plastic component 6 millimeters in thickness, and that was just too thin. It had to be 8 or more, and then it worked. Anyway, the new ones are totally different, and they last 20, probably 20, 30 years.
Yeah. My experience, John, is most people wait till there are more degenerative changes before they put in a uni compartment prosthesis, but I think that would certainly be an option.
Oh, I agree. It's just that this you gotta know the individual that's going to be doing this implant, and the implant is harder to do than knee replacement.
Right.
And then you gotta have the right person to do it.
Right.
And there are not that many around.
Right. Yeah. And so here are other images showing the attachment of the meniscus at the posterior and anterior horns. So that was just a good meniscal transplant that was in good position after it occurred. So the next thing that we look for is the size of the meniscus itself, and you can kind of measure the sizes and see if they're similar to what you would expect. But the main reason we measure the sizes in these is to follow it over time. Because a major problem with these meniscal transplants is that they start degenerating and you start losing the substance of the meniscus. So here we can see the anterior horn's a little bit anteriorly placed. We can see there's a little marginal osteophyte. There is some degenerative disease here, which brings down the prognosis a little bit in this particular patient. We can do those measurements. One of the problems with doing a lot of these measurements is with some techniques you can get metal artifact next to the meniscus, which can distort the meniscus and make it difficult to do the measurements, as we can see there. And then we're looking for signal intensity, just like in native menisci. Here we can see a meniscus is planted. We can see posterior horn, anterior horn. The anterior horn's a little bit anterior. The posterior horn's a little bit anteriorly placed. We can see that there's some cartilage loss of the femoral condyle here. And we can see there's a little bit of bone marrow edema here, probably from the previous meniscal tear and the reactive changes you can get after a meniscal tear. So this is on 11/19/09. This is a year later. And let's see, Michael, what do you think here is the difference? Should be the same one as yesterday.
I cannot hear you, Michael.
So
we're talking about Jennifer right now, John. Go ahead, Michael.
So both these are from.
This is 11/19/09.
Mm-hmm. And how long was this after the?
This is soon after the transplant.
Soon after transplant. So we see on these sagittal images that looks like a normal meniscus in good position. The coronal image is made a little far forward.
Certainly not a bad position. Here we can see the tunnels for the fixation.
This
is a year later.
So a year later, it looks like there's been it's kind of more increased extrusion of the body and the anterior horn of the meniscus. There's also a linear signal in the posterior horn, and there's also increased, chondromalacia and subchondral retention and marrow edema.
So this is one that didn't work very well.
Yeah, just kind of.
You can see that there's progression visibly.
What else do you see on this image of 11/18/10?
In addition to the extrusion and the degenerative disease?
Yes.
I'm not sure if we're looking at like the bone marrow of the.
Well, you have an effusion, but if you look at the condyle, a little more anterior than right there, that is that's osteochondral sort of kind of lesion, I think. Don't you, John?
Yes.
Okay, now this what I've read I never did any of these. I was getting too old and fragile to try them. And that is a contraindication to do a transplant as far as Campbell's is concerned. And Campbell's is, we use Campbell's as a great authority. and you cannot go wrong thinking that way about that book. That's the so-called Bible of orthopedics. So I have no experience with it other than seeing these images with John many times, and I would not do that knee with a transplant.
John, this is what the knee looked like when the transplant was done. And so this is right after the transplant was put in, and we don't see that osteochondral injury. This is a year later after the transplant's been in for a year.
Well, that just tells you the transplant wasn't working.
Right, exactly. So not all of these do well. We've had some do very well and others not do well. So Michael, this year with all the data that we have on these, I'm going to get that data to you tomorrow that I have, and we should talk about what kind of a study, what kind of studies we want to do. And this we've got a lot to do because we have, I don't know, 400 or 500 MRs in patients with meniscal transplants. So you decide what we want to do, and then we can all sit down and make the measurements.
Well, what is interesting is the degeneration is taking place awfully fast.
Yeah, this one of the fastest ones that didn't do well. We've had some others where the graft either tore early or displaced early. In fact, early on, displacement of the graft out of the knee was a very common finding. That's why we've looked at a number of different ways to try to stabilize it, to keep it in the knee. Though the data from Europe showing differences in outcome between transplants in the knee and transplants that have extruded from the knee show that there's not much difference in the two, which makes the whole concept of wanting to put in a transplant a little bit questionable.
Don't you think, John, that rejection in some of these cases is a problem?
You mean immunologic rejection?
Yes.
I don't, to my knowledge, they haven't really shown an inflammatory reaction to the menisci the way they're normally harvested in the commercial harvest banks. As you remember, John, Stone and I did a study on 10 transplants that we preserved in a different way. And in 8 of those, we got significant inflammatory reactions that were probably a reaction to the fixation agent that was used, if you remember that.
Yeah, you don't want to use any kind of fixation on these.
Right.
That is correct for sure.
Those were
I remember those. They were pretty ugly.
Yeah, those were in pig menisci because there was a shortage. In a lot of the world, it's difficult to get human transplant organs. In fact,
you can always buy one, John.
Actually, in Europe, they mostly buy them from the United States because they're not really available in Europe in a lot of different ways, and there are a lot of countries where they just aren't available. It's a real issue, but in the United States, they're available. At least they have.
Yeah. Like in I think it's Iran, you can buy a kidney. I don't think you can buy a heart, but they buy kidneys all the time.
Okay, yeah. Well, let's go on here. Jennifer, what do you? Well, let me just do this. So here is a meniscus, and we can. What do you think of this one, Jennifer?
Okay, so we have coronal and sagittal images of the knee, pre-graft meniscal disease. Looks like there's vertical increased signal intensity along the posterior horn. Looks like a peripheral tear.
Yeah, there's a lot of volume loss here too. That's the body and the posterior horn are very small. So you've lost a lot of the substance of the meniscus. So that was on 210 to 20. They put in a graft. I don't think we have images of the graft right after they put it in, but here's now 7 years later, and this is what the graft looks like.
It looks intact. There is some mild extrusion, but the posterior horn looks much better.
Yeah, so the posterior horn of the graft still looks very good. We have some degenerative disease in the body of the graft, but this patient was doing really well. Basically, had no symptoms. Had pretty much a normal knee at this particular time, except for the ACL graft that they had in there, but was doing very well.
I don't think I'd worry about the anterior meniscus. It doesn't look like there's any inflammation or any other problems.
Right. Great. I agree. And then the next thing we look for is fragmentation. This is really tearing of the meniscus. So you have multiple fragments. Ashu, what do you think of this one?
So we're looking at the lateral meniscus. Looks like the anterior horn is completely gone and displaced posteriorly. It almost looks like there's two.
You can see all these different fragments. Photograph here, where's fragments? So there's a posterior horn. That's a fragment right there. We can see a lot of fragmentation, displacement. So, and then obviously that's for the meniscus, and you look for progressive degenerative disease, which is quite common in these as well.
We don't know whether this was fresh frozen or not, right?
I'm trying to remember
how they preserved it.
Not. I don't really know, John. I was thinking that they were fresh grafts, but I don't know.
Oh, okay. Well, as long as they didn't use some chemical, that will cause this problem real fast.
Yeah. Okay. Michael, what do you think of this?
Usually that is glutaraldehyde, and people are too anxious to get to the surgery without washing the graft. The graft should be washed for 24 hours. If you're going to use a graft that's been put in glutaraldehyde to prevent rejection.
Yeah, I think that was a problem that we had with the pig grafts, is they weren't washed well enough.
That was my problem when I was doing the ligaments.
Is this post-transplant or is this?
This is post-meniscal transplant. There's 8/13/08 and 2/19/09.
Okay. So looks like maybe the MRI is slightly obliqued. I don't see the tibial plateau. But we can see a meniscus on a sagittal view of a meniscus. And it looks like its morphology is maybe there's some mild blunting of the anterior portion, anterior horn, but overall the morphology looks somewhat anteriorly.
More signal, getting some more subchondral disease there. Here are the coronal images.
Okay, so there's the increased signal in that posterior horn in the body of the transplant.
We see more erosive changes in color here. Here we can see a lot of increased signal intensity associated with degeneration of the transplant. And notice that the body is flattened and does not have the normal triangular appearance, both here, and then it's much worse as we follow. So this is just disintegration of the transplant over time. Okay, Jennifer, what do you think of this case?
So this is allograft placement, and these are from the same date?
Yes.
Okay.
Go, Jason.
I see. So it looks like they put some type of tunnel in to tack the meniscus down, but at the superior aspect of that tunnel, there's some type of reaction or fragmentation of the meniscus. So I'm not sure if that's not responding well, that part of the graft.
Okay, let me just kind of go over this. Here we can see a large osteochondral defect on the medial femoral condyle. For most surgeons, this would be a contraindication to putting in a transplant. This was a study looking to see if meniscal transplant could delay the need to put in a total knee to get by. But
this guy is borderline. Campbell's would definitely be upset about this kind of procedure. You cannot think of the meniscus lasting any length of time with a lesion like that in the condyle.
Yeah. And they did what's called a pace graft for the lesion here. We'll talk about that when we get to cartilage transplants. Now, what we see here is that this is the tunnel for the posterior meniscotibial fixation. And you can see that that's right here, and that's where the graft is. The next cut over, what we can see here is basically a line here, a dark structure posteriorly, and then the one anteriorly. What do you think's going on here, Jennifer?
So I think that they probably left some of the native meniscus behind and they put the graft in front of the native meniscus.
Right. So there was a lot of troubles with extrusion of the meniscus. So if there is a stable, intact peripheral rim of the posterior horn, they'll often leave it in to be a buttress to help stabilize the graft, and that's what this is. Good. So this is 3/19/11. This is what the coronal stir images show here. And then this is 6/6/11. What do you think is going on here?
So it looks like there's a worsening osteochondral lesion along the femoral condyle. And then also, I no longer can identify the native meniscus.
This is probably the native meniscus here. This
Okay.
is that peripheral rim that was left in. Let's go back for a second. Here is that osteochondral injury before, and here it is now. What you can see now is it's filled in a little bit with bone, and we actually have what looks like a form of cartilage here. So I think that osteochondral lesion actually got better. And this is typically what we see in these pace grafts, but we'll talk about those in detail when we get to articular cartilage. But what we don't really see now is the posterior horn of the transplant anymore. And so you have to go looking to see what happened to it. And what do you see on the coronal image here?
So here it looks like there's avulsion of the transplant horn at the root.
Good.
And it's displaced probably along the posterior tibia.
Yeah, it's really displaced medially here, and now the body's extruded. We need to see the more anterior coronal images to really confirm that. But it's what you really see is that this tore at the posterior meniscotibial fixation point and displaced laterally. And that's why we don't see it here, because it's displaced, it's displaced medially. So it's displaced more medially out of this particular sagittal plane. And that's why we have the big defect here. So that was an allograft tear. It's really a tear at the fixation point. Good.
Looking at the knee makes me feel pain.
Yeah, I agree. Really. Some of these look pretty bad. Okay. Issue?
This is a 51-year-old male with new pain after allograft placement. I think it's just the lateral compartment is complete chondral loss there, and I don't see any meniscus at all. Just looking at the coronal plane, it looks like there's absence of the body, I think, of the lateral meniscus right there, and I think we're looking for a fragment. It's just fractured. Okay.
That's what this was. This was just a transverse radial tear through the graft and displacement of the anterior and anterior to the posterior. So it's just a fracture of the meniscus displacement. And this is another kind of similar example where you can see displacement of the meniscus here. Instead of displacing out of the joint space like Jennifer's did, this one tore and part of it displaced inward and the other part displaced the opposite direction. So it's a displaced allograft. And then a fairly common finding that we've seen in these failures is this one. Michael, what do you think here?
So in the, this is I guess the meniscal transplant in the lateral compartment. So we see you don't really see the posterior horn of the transplant, and if there's, it looks like it's anterior to the anterior horn. So it's like almost a bucket handle that flipped over of the allograft.
It's like kind of like a bucket handle here. This is the posterior horn here.
Oh, that's.
So it's flipped around. This is the anterior horn.
Got it.
So it was a tear of the meniscotibial attachments and really kind of like a bucket handle tear anteriorly. So that's another displaced allograft. Okay. Here's another allograft. Jennifer, what do you think of this one?
With this one, there's complete absence of the allograft, and I see a decreased signal intensity structure extending along the femur. So I think it's flipped up into the superior recess.
Exactly. So this is a huge displaced fragment of the meniscus displaced out of the joint space. Okay. All right.
All right, we're looking at the lateral compartment. Looks like is this post allograft placement as well?
Yes.
Looks like there's an osteochondral lesion I see first at the lateral tibial plateau, some bone marrow edema, and then it looks very strange. The meniscus in this level, I don't really see if that's torn and then displaced into the intercondylar notch, or no, just displaced. Oh, superiorly. Okay.
So it's a displaced flat tear. And then you have to assess articular cartilage changes. That's what we're trying to hope to preserve, is the articular cartilage with these, and bone changes. And sometimes we've seen a stable disease over many years, but commonly over 3 to 5 years we'll see some progression like we see here. Here we can see that there's eburnation of the subchondral bone. The articular cartilage is markedly thin, probably denuded here, and we can see the development of subchondral cystic changes over time, which indicates progressive degenerative disease of the subchondral bone. And here we can see initially you had some reactive bone changes in the subchondral bone here, and over time we're just seeing much more bony disease and subchondral cysts in other areas. These are the transplant tunnels, so that the transplant is really on the lateral side, and we can see marked volume loss of the body of the meniscus as the meniscus degenerates, and this causes instability, and so we're probably getting traumatic injury to the bone even on the opposite side here due to the instability and the medial femoral condyle butting up against the tibial spines because you've got instability. So these are typical changes which we can see over time. Okay, see, Asher, did you do the last one?
Okay, so we can see changes in the medial compartment of tibial transplant. So I guess on the fluids, yeah.
So this is 11-1207, and we can see what looks like a pretty good transplant as far as the body goes, right?
Mm-hmm.
Little cartilage there. Okay, this is the same day. These are the sagittal images.
So it looks pretty good. Normal morphology of the meniscal transplant.
The fixation tunnels.
Mm-hmm.
Very good locations. Okay, this is 10-23-08.
Okay.
So it's 9 months later.
So 9 months later, it looks to me like the body of the meniscus is maybe a little more blunted in volume loss, and there's been progressive, cartilage loss throughout the medial compartment. Maybe there's a little more like subchondral sclerosis, not a lot of marrow edema. and a little more extrusion of the meniscus as well. So
we're just getting a little bit more progressive degenerative changes.
Mhm.
It's 917. This patient was pretty much asymptomatic.
Okay.
And so even though we saw a little bit of progression of loss of cartilage, the patient clinically did very well in this particular case. So there are a lot of questions that we still really don't know. If you get peripheral displacement, how much is too much? So that's something that we could look at. We could look at how much the meniscus extrudes and try to look at outcomes and see if there's any correlation between the amount of extrusion and the patient's outcome. The size of the meniscus, whether it's if the size is isn't close to what you would expect the native to be, does that have an effect upon the outcomes? Signal intensity, do they really correlate with outcomes? Fragmentation, see if any of the findings that we can measure on day one of the MR, day one after the transplant, whether any of things that we measure, such as location, positions, and so forth, or amount of cartilage loss, correlate with fragmentation of the meniscus down the line, and what time course. The other thing that we'd be really interested in is if somehow we could determine whether transplants are protective against cartilage changes. And here, one thing we could possibly do was if we could see those menisci that disintegrate soon or which extrude from the meniscus soon, whether those have a worse prognosis in terms of articular cartilage changes over time than those where the meniscus looks like it's functional and in proper position. That could be a very interesting study. And bone changes along similar study, but looking at the bone changes and not just articular cartilage disease. So things to think about as we go forward. Okay, see, Jennifer, what do you think of this one?
So this is a 29-year-old male with coronal and sagittal images. It looks like there's a complex tear of the body and posterior horn of the lateral meniscus. And then there's some edema within the marrow along the lateral femoral condyle. It's probably an osseous contusion.
Okay, here are the axial images.
So here again, we can see that complex tear along the body and posterior horn of the lateral meniscus and that adjacent marrow edema.
Yeah, so we're actually really saying this is a fracture of the meniscus. There's the edge of the anterior horn, there's the edge of the posterior horn, and there's a big distraction there between the two. And then, so this is on 6/25/13. This patient had a different procedure than we've been talking about. This is now the patient who came back after surgery on 7/25/13. And there we can see that now it looks like there's a meniscus there. But this was not a full transplant. What do you think might have occurred here?
It looks like they just did a transplant of the posterior horn and body. There's that screw or metallic susceptibility artifact that's extending kind of in the posterior femoral condyle.
You're talking about this?
Yes.
Okay. So, and then here we can see kind of postoperative changes. Even a little bit more bone edema here, but this body looks pretty good. There's a fixation tunnel here. This is what the original tear looked like. So you can see this is the fracture, the vertical tear that goes all the way through the meniscus. And there we can see the posterior horn and anterior horn are distracted from each other, just like we saw in the MR examination. So here's what they did as a segmental transplant. They took a segment of meniscus that fit in there. They cut the original one and then sutured that segment into place. We can see here. So it's called a segmental transplant. And I don't know if there's too much data on the success of these.
If you look above, the femoral condyle is really a big hole there. That's stage 4 condymalation, or stage 3, whatever you want to call it, or stage 6, depending on who you like. Anyway, that's a filler, and I guess the idea is that this may prolong the knee joint. I rather doubt it.
Yep. And I don't have any outcome information on this particular patient, but that's a segmental meniscal transplant. Okay.
All right, so 26-year-old male post-op with knee pain. See a tunnel through the lateral femoral condyle. Is that? Are they trying to tack on to the root? No.
What this is you penetrate the bone here in the notch of the knee in the non-articulating portion, stick a needle in there, and you aspirate bone marrow. It's called a bone marrow aspirate, and in that there should be some stem cells, and then you take those and you inject them into the joint space. And there's some people who believe that helps healing. To me, it doesn't make much sense, but there's a big debate now over whether this improves the rate of healing. By you can actually change. You can see that you can measure a change in the number of active molecules in the joint after you do an aspiration like that. So some people believe that you get biochemical factors and cellular factors that help the healing process. I think the data is not conclusive, but that's what that is. If you see it, you can see it in quite a few if you look for it.
Do they have they looked at PRP or maybe even platelet poor plasma?
People looked at PRP. I think most of that data is inconclusive. I think almost all the PRP data really is very poorly done. And
when you look at knee joint, the medial compartment, that's that meniscus is a goner, and is the idea that this whatever they're injecting is going to make the meniscus grow?
Well, it's something that some surgeons do routinely now. Every time they do arthroscopy, is to do these bone marrow aspirates and inject in the knee joint. And I don't know that if there's good data to show that it helps the healing, like in an ACL graft, whether you get better repair, or whether it's a reimbursable, something that you can do in the knee to increase reimbursement. I'm not sure.
My thought when I first saw this, John, was that they were using some kind of a material to tack the ACL to the lateral condyle, but I don't see the hole there.
Yeah, no, this is what's called a bone marrow aspirate, and it's a controversial area in orthopedics now.
I haven't had any reading on this one.
Okay. What do you think of the medial meniscus?
The medial meniscus looks, partially extruded into the meniscal gutter. And it's kind of got abnormal morphology a little bit. I don't see like increasing.
It's very black.
Mm-hmm.
Here are the sagittal and axial images.
So there's some metallic artifact kind of surrounding the meniscus. So is this some, post-meniscal transplant?
This is another segmental transplant.
Does those look like,
These are the suture fixation sutures for the transplant that's been cut and put into the body, like the last one. But sometimes they use metal fixation, then you get a lot of metal artifact, and that's what that's from. Okay. Jennifer, what do you think of this one?
So this is arthroscopy with ACL revision and lateral meniscal transplant, and she does not have a pulse after surgery. There's
Why didn't she have a pulse?
Well, I see some increased signal intensity along the posterior joint space. I'm worried there could be maybe a laceration of the popliteal artery and hemorrhage.
Other images.
How do they do these procedures, with or without a tourniquet?
I think they use a tourniquet.
Oh, absolutely, because they take quite a while, and sometimes the tourniquet is left on a little longer than it should, and ergo you get a thrombosis someplace. I don't know whether any injury was happened to the artery, but you don't see a bunch of blood anywhere, do you?
Well, I saw some increased signal material along the posterior joint space. I don't see it here.
John, why don't you explain where they put the tourniquet and why they put a tourniquet at surgery?
Well, the tourniquet is used for no more than an hour. And when you're doing a long procedure like this, 45 minutes to an hour is okay. And then you let the tourniquet loose, catch some bleeders, and then inflate it again after 15 minutes, and then you can proceed. And that's what you use a tourniquet for. Some tourniquets in the past were made very stiff, and they really caused a lot of problems. But that issue has been solved. But you cannot do this procedure without a tourniquet in any way.
So you put a tourniquet on the thigh to decrease.
Yeah, it's on the thigh below the hip joint, as high up as you can put it, where there's the most amount of muscle, and you have to watch it and palpate it and make sure that it's on properly. Usually, you can tell whether the tourniquet is on properly or not, because you'll see bleeding if it's loose. But some tourniquets are turned on too high. And I remember when I made it a point for our hospitals that the tourniquet should not be turned on more than 300 to 350 millimeters of mercury, because they were putting the tourniquet on to 450, 500. That can give you necrosis. And anyway, that's about it about a tourniquet. It's a very old technology. Going back.
So Jennifer, what do you think on the axial images here? Here's one set of axial images. Here's an adjacent axial images. Oh, let's go back here. There. And then here. And this is the...
Yeah. It looks like there's that intermediate signal intensity there in the expected region of the artery, so there isn't a flow void. Yeah, I think maybe there's a clot or a thrombus there.
Right. And here we can follow it up. And
I'm really surprised they did this MRI after surgery and they didn't just go straight for a CTA.
yeah.
I certainly agree with you.
I don't remember the details of how this occurred, but there was an injury and a clot in the artery. They had to go in and declot it. Right. Okay. All right. So let's talk about the meniscal ligaments. There are the meniscofemoral ligaments, which are Wrisberg and Humphrey. There's a transverse ligament, and several meniscomeniscal ligaments, and the anterior iliotibial band-meniscal ligament AIML, which we've already seen an example of. So we've talked about Wrisberg's ligament. It goes from the posterior medial aspect of the medial femoral condyle inferiorly down to the posterior horn of the lateral meniscus near the meniscotibial attachment. And Wrisberg's ligament goes posterior to the PCL as we see here. It's very common. It's considered really a normal ligament. There we can see the Wrisberg's ligament back here. And it comes down here near the posterior horn, and here we see it attaching to the posterior horn. This is a situation where the meniscotibial attachment is either very lax or not present, and traditionally you'd call this a Wrisberg's variant that we talked about in this particular patient. And then now, here's the sagittal images. It looks like there may be a Wrisberg's ligament right back there, but if we go to the coronal images, we can see that it's actually spherical and not linear, and this is a loose body that sits set back there that looked like there's a Wrisberg's ligament on one sagittal images. Humphrey's ligament goes anterior to the PCL. Usually you have one or the other. Occasionally you can have both, but that's pretty uncommon. And that's so it's the same course, but it goes anterior to the PCL. But you can also, if you get the situation with either of these ligaments, if they're in place and you get an ACL tear and you get rotatory instability and a pivot shift mechanism of injury, that the attachment of Wrisberg's ligament to the posterior horn of the meniscus can cause a rupture at that attachment. This happens to be a place where Humphrey's ligament attached, and this was a fragment of the posterior horn that was medially displaced at the time of a pivot shift mechanism of injury, which produced a rent in the posterior horn of the lateral meniscus. So that's something to be aware of whenever you see an acute ACL tear. It's important to look at the posterior horns of both the lateral and medial menisci. We've already talked about ramp lesions in the medial meniscus, but you can also have these Wrisberg and Humphrey ligament avulsions from the posterior horn of the lateral. So here's just an example, an ACL tear we see here. Here's Humphrey's ligament there, and it came down and attached to the meniscus and actually pulled the meniscus over. The other thing that you have to be a little bit careful of is if you have a normal meniscus, this is not normal. You can see an injury here. At the cut just medial to where the Humphrey's or Wrisberg's ligament fuses with the posterior horn of the lateral meniscus, you can have a little defect between the two, which is a partial volume of just the normal structure where the two are close to each other but haven't fused yet. And you shouldn't call that a tear. So you have to follow that all the way to the next cut laterally. And if you see that it's all black and they completely fuse, then you just get partial voluming the interspace between the two, and it's not a tear. So you have to be careful of that. Okay. Another ligament anteriorly is a transverse ligament. And it goes from the anterior horn of the lateral to the anterior horn of the medial. And the reason this is kind of important is when we were first doing MR of the knee back in the late 1980s, we had a running back. That was back when the Raiders played in Los Angeles. And we were doing the imaging for the Raiders, and we had one of the Raiders, their star running back, came in, and we saw something that looked like this, and so we called it tear in the anterior horn. It's usually the lateral meniscus. This is medial here, but you can also see it in lateral. that was on a Sunday evening after the Sunday game when he was injured. They were thinking about surgery, but then by Tuesday he was asymptomatic, went back into practicing on Wednesday and Thursday, and that next Sunday, after we made the diagnosis of an anterior meniscal tear, he broke the NFL record for the most number of yards made in any one game. And in retrospect, we went back and could see we could follow this little black structure here all the way through the knee and saw it fused to the anterior horn of the other side. And then we looked up in some obscure texts of anatomic texts that there was a transverse ligament there. And so, and this is what it looks like. This is a typical appearance of right near where the transverse ligament attaches to the anterior horn of the lateral meniscus. You can get normal partial volume of the interspace between the two. The next cut's black, then it's fused normally. And so the transverse ligament can mimic an anterior tear. And we kind of learned the hard way back in those the first few months that we're doing MRs of the knee. So that's a transverse ligament. You can see it now fuses nicely here, so there's no tear there. So that's the primary reason to be aware of the transverse ligament. And then you can follow the ligament all the way across the knee to where it fuses now with the anterior horn of the medial meniscus. And you could also misinterpret this as a tear as well. So that's why it's important to be cognizant of the transverse ligament. Then there also
there were many meniscectomies done before people knew about this. It's
okay.
They would take out the ligament and think that that's a meniscus tear, and it's a partial meniscectomy, they call it. Those days are long gone, but that used to happen.
Well, we published that pretty soon afterwards, so at least in the MR literature, it's been known for a while. There's the transverse ligament we just talked about. You can also
John, I was talking about before.
Yeah,
all the studies.
Yeah.
That we have.
Yeah. So, and then there's a meniscomeniscal ligament. The most common one goes between the anterior horn of the medial and the posterior horn of the lateral through the notch of the knee underneath the cruciates. This can be misinterpreted as a bucket handle tear. And as you already know, you can have the same side meniscomeniscal ligaments, which can look like a ring meniscus or be misinterpreted as a bucket handle tear. And if it's small, we usually call it a ligament. If it's larger and it's triangular in shape, we call it a ring meniscus. All these are very rare. Bucket handle tears are 100 times more common. So, but if it's nice and smooth and looks normal, just remember that you can have a meniscomeniscal ligament of the same meniscus or a ring meniscus as a normal variant. But the meniscal ligament is actually fairly common if you look for it. Here's what it looks like on the axial images, going between the anterior horn of the medial, posterior horn of the lateral, through the notch of the knee. This is what it looks like in the coronal plane. So it can be misinterpreted as a little bucket handle fragment, but notice that the body has a nice, sharp, triangular appearance. If it were a bucket handle tear, you'd have a longitudinal vertical tear here, and this part of the meniscus would be flipped in there, and that's not the case here. So this, and if you follow it, it goes between the anterior horn of the medial and posterior horn of the lateral. So that's a meniscomeniscal ligament. And there's an example of a meniscomeniscal ligament that looks like it could be a loose body, but you have to follow it and see where it goes, and it goes between the two menisci.
That's pretty uncommon, isn't it, John?
Actually, if you look carefully for it, this intrameniscal ligament is commonly present. It's usually small. Most people never even notice it. But if you look carefully, you can see these fairly frequently where they go between the anterior horn of the medial and the posterior horn of the lateral. The others are extremely rare. But they shouldn't be misinterpreted as a loose body. That's the issue. And here's just another example of the intrameniscal ligament. Okay. I think we've already seen a case of this. It looks like there are two ACLs here. And if you follow it, you can follow it up. And there's another example. These are all variants where you have a ligament from the anterior horn of one of the menisci, extend anteriorly, paralleling the ACL and attaching up here. And these are called anomalous insertion. It's almost always in the medial meniscus. So that's what that looks like. So you just have to be careful to realize that this can be a normal variant and doesn't necessarily mean a tear, but you have to look at everything else. The other possibility here is you could have a partial tear of one of the two, either the anteromedial band or the posterolateral band of the ACL, which can occasionally look a little bit like this. So you just have to see where it's going from and make sure these are also quite rare. But they can be misinterpreted if you're not aware that you can have a normal anatomic variant there. I think we already talked about this particular one before. Okay, and then here's a 15-year-old male, chronic knee pain, rule out meniscal tear. And here again, what we can do is we can see this fibrous structure here going anterior to the ACL, and you follow it down and see if it goes to the anterior horn of the medial meniscus. And here we can see it coming down here, and you can follow it all the way down to the anterior horn of the medial meniscus. So this is an anomalous insertion. And the other name for it is an Anteromedial Meniscofemoral ligament. So just be aware of that anatomy. I don't remember what this is all about. Oh, I'm sorry. That's what they said here was that if you have the anomalous insertion of the anterior anomalous band, that you're much more likely to get an injury to the anterior horn of the medial meniscus than if you don't have one. And you can see that you have increased risk of edema within Hoffa's fat pad, increased risk of tears to the body of the medial meniscus and the anterior horn if you have these. So they may abnormally constrain the anterior horn and increase the risk of having a meniscal tear due to abnormal fixation. There's just an arthroscopic view of these, which we can see there.
Can you go back to that, John? That just looks like scar.
This is an anterior iliotibial band-meniscal ligament. I'm sorry, this is another one. Let me go back here for a second. No, that's a different one. So this is actually, you can also get a band from the anterior horn of the medial meniscus to wait a second. Just a second. Oh, okay. So this goes from the anterior horn of the medial meniscus all the way across to the iliotibial band, and this one can lead to increased risk for injury. But that's going to the lateral. That one looks like it goes to the lateral. Look, let's forget this. I'm going to have to go back and review this article. This is a recent article in 2019.
Questionable.
Yeah. So this looks like this is going from the iliotibial band to the anterior horn of the lateral meniscus, which we can see here. And so that's another variant. John, you say it looks like scar tissue. I guess
it sure does. It looks like there is a tear of the iliotibial band, and the scar, the tear occurred, and it's hugging the condyle.
Okay.
That's just my opinion. It looks like it's part of the structure there's a structure anterior. So you see two structures, and there's a hole in there, and I think that's just a tear away from it. It's like a meniscal tear,
yeah.
But it's not the meniscus.
Yeah, but the distal iliotibial band has several attachments. One is posterior. The big one is along the anterior lateral margin of the tibia. And then I think occasionally you can have another attachment which goes to the anterior horn of the meniscus. And that's what they're talking about here. I'm beginning to remember.
Well, the condyle would be aggravated if it was due to this, and I don't.
Maybe it is.
Oh.
In this particular paper, they were just looking at the meniscus, and what they showed here is you'd had a significant increased risk of tears to the anterior horn and the body of the lateral meniscus if you have this congenital variant. That's what this paper was. I'm sorry. I had forgotten this. And these are just MR examples of that iliotibial band coming down and attaching to the anterior horn of the lateral meniscus along there. Okay. And then we all know that you can get degenerative disease associated with meniscal tears. When you have a tear of the meniscus, the biomechanics is altered. You get increased stress and also abrasion adjacent to it, which can give you both cartilage disease and disease to the subchondral bone, which is quite common. In fact, back in the late 1980s, like 1986 or 87, there was actually a paper in radiology which said that a bone scan was 90% sensitive for detecting meniscal tears. Obviously, what the bone scan is detecting is a bony reaction from the tear. So and it turns out that wasn't very specific and so forth. But anyway, there were some people for a short time recommending bone scans to evaluate for meniscal tears. That just shows the subchondral reaction. And there's the bone scan showing the change that you can see on the bone scan. Okay, I think this is the last case for the menisci. Who's next? Okay, what do you think of this?
All right, looks like there's the medial meniscus looks like there's a lot of edema. The body of the medial meniscus looks absent. There's a subchondral.
Actually, technically, it's not correct to call this a knee.
Okay.
You can see there's a meniscal tear here and some bony reactive change.
Oh yeah.
And here are the sagittal images. And you can just see the crucial ligaments.
Yeah.
And this was a sled dog with a lamp.
Okay.
With a meniscal tear.
John really gets fellows with this one.
Okay, so
Yeah.